Thanks very much, everyone, for the opportunity to present today. And I'm conscious that we're running a bit behind, and I'm talking between you and lunch, so I'll keep it fairly quick. So fascinating talks this morning in innovation and technology, and I'm going to bring it back to basics a bit today and talk about a feasibility study that we have just started up in Ambulance Victoria. So we'll talk a bit about the international burden of sepsis, time to first antibiotic dose, and extending the point of care medicine into the pre-hospital setting, and why that's relevant in the case of sepsis. So we've done quite a lot of work in other key conditions in terms of bringing the point of care testing into the pre-hospital environment. For example, our 12 leads and thrombolysis with STEMI, our pre-hospital red cell concentrate with our major trauma patients, stroke, and now we have our stroke ambulance in Melbourne, which you've heard some amazing results from. So what about sepsis? And sepsis is a significant issue in our society, and there's certainly a lot more than paramedics could do in that space. So sepsis, there's a significant international burden. It's one of the most frequent causes of emergency department attendances worldwide, with an estimated annual incident in adults of up to 300 cases per 100,000 population. And that equates to about 18 million cases per year worldwide. It's recognised by WHO as a global health priority, and we see approximately 20,000 cases in Australia per year. And we know that mortality increases with delays in treatment, and there's an increased incident in the elderly and the chronically ill. And the elderly and the chronically ill are the patient population that ambulances are seeing more and more. So there's definitely a role for us to play. And they have a high mortality rate. So the hospital mortality rates for patients with severe sepsis sit around the 20 to 50%. And that greatly exceeds mortality rates that we see in things like myocardial infarction, stroke and traumatic injury. So a significantly ill population but to date there's been very little focus on sepsis in the pre-hospital environment. And even recently in Victoria, Safer Care Victoria spent a lot of money on sepsis programs and allocating additional staff for sepsis, but none of that was allocated to the pre-hospital environment. So I think there's a lot that we can do. Now, there's been quite a bit of literature on sepsis and the fact that reducing time to treatment reduces mortality and morbidity. And one of the key studies was by Kumar, published by Kumar in 2006. And it was a multi-centre retrospective cohort study. They looked at over 2,000 patients with septic shock who received antibiotics after recurrent or persistent hypertension. Survival was about 83% if effective. Antibiotics were administered within 30 minutes of initial evidence of hypertension, and then reduced to 77% in the second half hour and 42% in the sixth hour. So it was really a ground-breaking landmark study demonstrating that reduced time to care improved outcomes. And they said that for mortality increased by around 7.6% for every hour of delay in starting antibiotic therapy after the onset of hypertension. Then there was another great study published in the New England Journal of Medicine, and that looked around implementing a sepsis bundle of care. So it was a 3-hour bundle, and things like blood cultures, lactate, fluid, antibiotics, and they showed similar relationship between delaying implementing the bundle of care and patient mortality, and one of the key factors was time to administration of antibiotics. And similar results coming out of Australia as well, with the Sepsis Kills program in New South Wales, showing that delayed time, after they implemented the program, mortality significantly reduced, and one of the key factors in driving that was time to antibiotic administration. So administering antibiotics within an hour increased from around 30% before the program was implemented to over 50% after the program. But there's been a meta-analysis that's been published in 2015, and they found that from their analysis that the timing of antibiotics on outcomes in severe sepsis and septic shock showed no significant mortality benefit of administering antibiotics within 3 hours of ED triage or in 1 hour of shock recognition. So there's still some controversy around it. And I'm sure a lot of you are probably aware there actually has been one pre-hospital randomised controlled trial published. This was published in The Lancet in 2017, and it was based in the Netherlands, where paramedics were randomising patients to early antibiotics versus normal care in the ED. But I think this trial still has some questions that are yet to be answered, and particularly I think that, as I often talk about with research with EMS, it's very important to demonstrate effectiveness in your own environment. So some of the things that sort of I question about this trial, the randomisation is a bit suspicious. So there were significantly more patients randomised to pre-hospital antibiotics and more positive blood cultures in the intervention group. The time to antibiotic administration was only 26 minutes earlier than ED. They had a high do not resuscitate order rate, and with the training that came with the trial, there was a real narrowing of time differences across both groups. They have different inclusion criteria to the study that I'll be talking about. And their ICU admission was only 10% and mortality was 8% in both groups. So the trial basically showed no impact of early antibiotics. But 75% of patients were referred by the GP and 20% were already on antibiotics of some sort. A few of the positive things that have come out of that trial, I think, though, is that they recognised there was a clear lack of sepsis clinical practice guidelines in the Netherlands, and they created a new comprehensive one. So one of the benefits of participating in trials in the pre-hospital environment is the scrutiny on the care, the standardisation of care, and the increase, the better outcomes that patients can get just purely by participating in research. And they only had 7 patients with a mild allergic reaction, and none of them were related to the antibiotic. And then, following on from that, another observational study that's just been published this year in Chest did a retrospective cohort on all non-traumatic adult patients with sepsis admitted to 4 hospitals. And they used statistical techniques to adjust for a number of things and look at the relationship between door to antibiotic time and mortality. It was a large study, over 10,000 patients, and there was quite a delay to antibiotic administration. So medium door to antibiotic time was 166 minutes. And quite sick patients, 1 year mortality, 19%. And they clearly showed, after adjusting for known confounders, that each additional hour was associated with 10% increase of 1 year mortality. And they saw similar results in all the sort of subgroups that they looked at, and in shorter term outcomes in terms of 30-day and 90-day mortality as well. So that brings us on to the PASS feasibility study. It's a phase 2 randomised controlled trial looking at paramedic antibiotics in severe sepsis. Its primary hypothesis is to show that patients who have community-acquired sepsis, when evaluated by paramedics, will have a significant reduction in time to appropriate antibiotic treatment compared with standard care. So phase 2, we're focusing on the fact that we're reducing time to antibiotics. The results from this will then be used to go to a larger phase 3 trial, which will be looking at the impact on patient outcomes. So we propose, based on data that we've crunched, that the initiation of antibiotics pre-hospital result in an absolute reduction in time to antibiotics of at least 60 minutes. And we actually looked at, so there was the ARISE study, which was a multi-centre study that was published a while ago, and we asked the ARISE investigators if we could get the Victorian data for that. So these were all significant sepsis patients. We linked the ARISE data to our Ambulance Victoria data, and of the 341 patients that were enrolled in ARISE, 70% were transported by us. Paramedics noted infection in 70%, and they were quite sick patients, so 63% febrile, 71% tachycardic, 62% hypertensive, and 37% confused. And the QSOFA, which is a tool to to try and detect sepsis was only positive in 58%, and they were quite sick, so 90-day mortality almost 18%. So we used that data to extrapolate the likely benefit of time difference if we implemented antibiotics in the pre-hospital environment. So from the linked data, we saw that the mean paramedic contact time from at the patient to off the stretcher was over an hour, and the median time to first antibiotic administration in the ED from loading the patient into the ambulance was 107 minutes. So significant opportunity for time saving in the pre-hospital environment. So we're really looking at, can paramedics successfully diagnose suspected sepsis, and importantly for this trial, can they take blood cultures in the pre-hospital environment without contamination? And that's one of the key things that we'll be looking at. So some of our secondary hypotheses are that administration of the antibiotic will result in minimal adverse events, it won't result in significant increase in scene times, and that they can proficiently perform blood culture collections. We'll also be looking at 90-day functional outcome, but the trial isn't powered to see a difference in that. So this is an example of the randomisation pack. We're including patients aged 18 years and over with a history or symptoms suggestive of infection. The GCS is less than 15, excuse me, and blood pressure less than 100. And at the moment it's just a feasibility study, so we're enrolling patients who will be transported to the Alfred Hospital, and we've chosen one rural hospital, which is Bendigo. Exclusions are females known to be pregnant, suspected allergies to penicillin, suspected meningococcal infection, because we will treat that straight away, deranged clinical parameters that are considered to be unlikely to be from a non-infective cause, such as dehydration, acute coronary syndrome, anaphylaxis, excluding patients already receiving antibiotics, particularly hospital in the home, and we're also excluding patients who've been an inpatient in a health facility in the last 7 days. That's just the process. So we're only including 110 patients because our outcome is demonstrating reduced time to antibiotic administration. And we're hoping that the results from this will provide a robust rationale to get funding for a much larger randomised controlled trial. So just a little bit about the pre-hospital blood collection, and that's really what a lot of the training for the paramedics has been about. So we're doing the gold standard. We're requiring 2 sets of blood cultures to be taken, which means 4 bottles, so an aerobic and an anaerobic collection. So we need at least ideally 40 mils of blood. So there's been a lot of training around how to do aseptic blood culture collection, which has been fantastic. And also importantly, again, the gold standard, because the randomisation packs have the pathology slip already completed, and we need to have 5 points of identification for that pathology slip to effectively go through the hospital. So we've had a big emphasis on that as well. And there's quite a lot of work the paramedics need to do in order to be accredited to be enrolling patients in the PASS pilot. And I'm happy to say that we just started last month, and we have over 100 paramedics already accredited. So where are we? We had a very soft start in July because we didn't have all of our paramedics trained, and we've only got the Alfred on at the moment. Bendigo is just finalising ethics. We've had 10 potentially suitable cases, but 9 of them were ineligible for a number of reasons. So 4 had been in a healthcare facility in the past 7 days. 1 patient was allergic to penicillin. 2 had already received antibiotics. In 1 case, the paramedic was not accredited, and in 1 case, it was a non-participating team. But we enrolled 1 patient, and unfortunately we couldn't obtain IV access, so we couldn't get blood cultures. So we couldn't actually randomise them. But nice to see that they actually went straight through to ICU and they were diagnosed with sepsis. So 100% diagnosis rate so far, which is great to see. And just like to acknowledge the past trial investigators, in particular one of our senior paramedics, Dan Cadini, who has just been put so much work into training and developing all the material. We have a page on our website which is all the we've got videos around aseptic blood techniques and frequently asked questions. And ICU consultant Andrew Udi, who's also been dedicating a lot of time visiting branches and training. So always takes a big team with these trials. Thank you very much.